Contralateral C7 transfers for spasticity has been a contentious topic among hand surgeons and neurosurgeons. However, its role in lower motor neuron is fairly well established, especially in pen plexus injuries, and is a known strategy for most centers, especially in Asia. My name is Vaikuntan Rajaratnam, and I'm going to talk today a little bit about the philosophy of how the central nervous system is affected by contralateral C7 transfers and how this has a part to play in neuroplasticity and adaptation that occurs after stroke. And I will go through some of the literature, the evidence there, and a personal experience with the use of contralateral C7, early experience. I feel that this is an important strategy that we need to keep in our armamentarium, and there's much more work that needs to be done on the role of contralateral C7 transfers and its impact on the central nervous system as the patient continues to rehabilitate and recover following a stroke.
Our brain is the seat of perception of our universe and the seat of volition and how we execute function. And in this information processing system, which I have modified from the models both in computing and in the brain, you can see how the mind, which is a function of the brain, perceives our universe through our senses. And the peripheral nerve is one of these tissues that provides the senses, and is also the tissue that executes the response through a motor action. The other functions which we won't go through, but for us to understand how we impact the peripheral nerve, this is a good model for us to look at. We are familiar with the various pathways. It is important for us to revisit how the peripheral nerve is connected to the central cord, to the central nervous system, to the spinal cord. The lamination of fibers are represented not just only in the brain of the homunculus. Similar homunculus are seen in the spinal cord. This is important for us to understand because interventions can occur at various places, and this organization and complex synapses are important for us to utilize in understanding and in managing nerve injuries.
Contralateral C7 transfers for the reanimation of the upper limb has been well established since 1986 for brachial plexus injuries. Recently, it has also been used for spasticity and has documented that the donor defects are compatible with function and has significant improvement in functions in the upper limb. Recent studies have clearly shown the anatomical basis for the outcomes seen in contralateral C7, and this review is worth a read to understand how the contralateral C7 produces functional outcomes in the motor of the targeted muscles. In this landmark paper by Sheng et al. From Shanghai on a randomized controlled trial showed the superiority and functional outcomes from contralateral C7 transfer as the intervention in post-stroke spasticity with outcome measures both in the Fergal-Meyer score and the modified Ashford scales with improvement. Donor mobility was minimal and was recorded and was compatible with function. This set the stone for the extensive use of contralateral C7 over the last 10 years in the reanimation of the upper limb in post-stroke spasticity. In this recent paper by Lee et al. Had shown the structural changes that occurred following contralateral C7 transfer using tectographic MRI techniques, showing that the improvement in function was secondary due to structural changes in the pathways as a result of this nerve transfer. This slide from the paper shows what happens to the
connections in the brain. Before surgery, you can see that the corticospinal tract on the injured side shows limited activity as a result of the trauma. But after surgery, there's a new connectivity across the brain's corpus callosum, demonstrating successful nerve transfer and the potential for improved motor function. So this provides the basis, the anatomical basis for what happens centrally following contralateral C7, and is something that we need to look at, and the deep neural networks that occur in the brain to facilitate neural plasticity is going to make a significant difference in how the outcomes from contralateral C7 is. There are things that we may not understand, but the availability of an anatomical connection between the right and the left side through the contralateral C7 would facilitate, as shown by here, the added connection between the right and the left brain through the corpus callosum, and this can help in the rehabilitation in neuroplasticity.
So, in order to understand how the knowledge is evolving on the role of contralateral C7 transfers for spasticity, we conducted a scoping review using the terms contralateral C7 and spasticity. Obviously, there are a lot of publications on the role of contralateral C7 transfers for lower motor neuron lesions. However, there are only 7 papers that fulfill the criteria, and this is a summary of the findings of this paper. Most of these papers came out from China, bar one, which was a review paper and not primary data. A lot of the papers were also relating to surgical techniques of the contralateral C7, the paraspinal, the prespinal, the pretracheal, the prevertebral, and there was only one paper on the use of the both contralateral C7 and L5 to S1 transfer for hemiplegia. The landmark paper is obviously the randomized controlled trial of 36 patients, which I've mentioned earlier. So it is worth your while to look at this table if those of who are interested in to see what is the evidence for contralateral C7. Obviously, this shows there's a tremendous scope for further research with further observational studies on the role of contralateral C7.
We'd like to present this 37-year-old male who had a right upper limb spasticity. As you can see here, it's quite moderate spasticity, and this is a result of a head injury with road traffic accident that we saw about 4 months post injury, and he had the difficulty in using his right upper limb. And if you look at his face, you can see there is an increased cognitive load in an attempt to do voluntary movements, and the spasticity is quite significant. The main findings are the shoulder and elbow functions were good, but we can see that the forearm is pronated, the wrist is in a relatively neutral position, and the thumb has got a slight thumb in palm deformity. And there's stiffness noted in the extensor pollicis longus and flexor digitorum superficialis. And the thumb can be brought to full extension, and he also had global aphasia. And based on these characteristics, we planned a contralateral C7 using a sural nerve graft to bridge the gap, as we did not want to do too much of dissection, to do a prevertebral route, to do direct coaptation of the contralateral C7. In this slide, we look at what are the indications for contralateral C7 in spasticity. So for my understanding of the problem and what I have read through in cognitive neuroscience and in central nervous system synapses and neuroplasticity, if you have a chronic spastic paralysis of the upper limb, there is not improving with conservative management, and the injury is unilateral and not bilateral. However, we have also done some form of nerve surgery in terms of neurectomies for patients with focal dystonia, and in a couple of months I will be doing a case of Wilson's disease with a similar form of spasticity, and we're going to try to see whether contralateral C7 or neurectomy will be useful. There must be significant functional impairment, otherwise I don't think this is a surgery to be attempted. And I would add if there is significant aphasia in conjunction with the speech therapist to see whether the neurectomy from the C7 on the affected side and the contralateral C7 transferred from the normal side would improve aphasia, as we have a case that we can see there is a slight improvement. And again, the duration of the paralysis, as you know, there is a flaccid stage and a spastic state. Usually, I would probably wait between 6 months to a year till we see a plateauing of the spasticity, but making sure there's sufficient intervention in terms of splinting and stretching to keep uh, the spasticity relatively stable without the formation of contractures. So once the contractures are formed, then the effect of of any form of nerve surgery is going to be reduced, and I would wait for a plateauing of the clinical state before offering surgical intervention in the form of contralateral C7. And there must be all the deformities should be correctable with relaxation. If they are fixed contractures, then this may not be the surgery of choice. Now, the spasticity has to be moderate to severe. Mild spasticity, I don't think would benefit from this form of surgery. And if you see there's a possibility of increased cognitive load on the patient, the cognitive load, as I explained earlier on, is a result of hyperexcitability of normal neurons around the area of the upper motor neuron lesion that makes it difficult for the patient to perform a motor task. So establishing the cognitive load, sometimes you can see this in the patient's face. You need to ask that he takes too much of an effort and that he would give up because the rewards are not there for the effort put in. And that's what happens, and the neurorehabilitation becomes a difficult task. Now, there must be obviously a functional impairment, otherwise you should not be considering this form of surgery. There must be significant amount to affect activities of daily living. Also, if there is a poor progress in rehabilitation, I feel that this procedure can increase the outcomes from rehabilitation. It primes the central connections, the neural connections, synapses, and plasticity to help with neural rehabilitation. The other thing is, if previous conservative management have not been very useful and there's poor progress in rehabilitation, and I would add another indication: if the patient is very, very motivated and is keen, is understands the rehabilitation and the limitations of this surgery, then it will be worth the while to consider. The other thing to look at would be the donor nerve. The contralateral C7 obviously must be available, and you must, if you want to keep the procedure simple and do a subcutaneous tunnel to cross the opposite side, then the pseudo nerve graft helps to bridge the gap because it won't be able to do primary coaptation unless you want to take the prevertebral route, which has got its challenges. However, there are some who have tried, especially in lower motor neuron lesion in pediatrics. They have used allografts like exogen to bridge the gap. Then you must also look at the anatomy, whether the is suitable. There's the anatomy of the neck is fairly good bed for a transfer, especially if you're pushing a graft. The bed must be sufficient vascularity to allow for the success of a nerve graft, and obviously the availability of a sural nerve if you're contemplating a graft. However, if there's a allograft, you could do that. So the justification for us to perform this contralateral C7 in this patient was we have strong evidence in MRI that supports contralateral C7, and the benefits would be it would reduce spasticity on the affected side because it's a neurectomy, it's a high neurectomy of C7, and that would get immediate results as we show in this case. And there is a significant improvement in the literature that there is improvement in motor function, and it therefore the data that we have, both MRI
and clinical data that validate the proposed surgery. The limitations of this procedure is one, there's a long delay in motor recovery. It's not totally predictable, but I feel that the reduce in spasticity from the neurectomy of the affected C7 is beneficial. And if you're using our nerve graft, then there's two neuroropathy sites, and that comes with its own problem. And there's been a fear in the West, especially of taking the contralateral C7, which is the normal part, and that danger of producing significant motor and sensory deficits. And I've been using this a lot in lower motor neuron lesion, and I've never had a single case. And the literature also says there are hardly any motor deficits or permanent sensory deficit, most recovering within 3 months. And obviously the surgical complication, especially if you're taking the prevertebral route or the intraspinal route, which are higher risk because they involve spinal surgery with bleeding, scarring, and technically more demanding. But you must realize the contralateral C7 is a complex surgical procedure. I think most nerve surgeons are quite comfortable, except those who have never done contralateral C7, but it's a very easy procedure to learn for nerve surgeon. And the handling of the nerve is paramount. And again, this is not a problem for nerve surgeons. There is some uncertainty in the long-term outcome. We're still early days. I think more research needs to be done, but we need to push the boundaries for this type of surgery. This is the diagram shows the type of surgery. We didn't do the prevertebral. We did the subcutaneous route, as shown by the diagram in the front. The blue is the healthy nerve that was taken from the contralateral side. The green are the pseudo nerve graft, and the orange is the contralateral, the ipsilateral C7, through which we are neurotizing with the normal from the normal side.
ភាពយើងអាចនិយាយបានប៉ុណ្ណាណាឈ្មោះអីធ្វើការអីនៅណាចឹងនិយាយទៅកុំអត់និយាយខ្លួនឯងឈ្មោះអីឈ្មោះអីឡើយហ្នឹងធ្លាប់ពីមុនមកធ្លាប់ធ្វើការដែរ he just put like that say art it means nothing no
He cannot hear anything.
he hears but he
Cannot say. Okay, he's got an aphasia.
This is the patient positioning for the contralateral C7 done under general anesthesia and ensuring that within 10 minutes there is no neuromuscular blocking agents, as we will be stimulating to detect the contralateral C7. This shows the C7 donor, the contralateral C7 that has been divided. The loop is around the distal end, and the forceps is holding the proximal end of the contralateral C7, and the pseudo nerve graft will be coapted to that. This is the patient immediate post-op. You can see a complete reduction of the elbow spasticity as compared to the pre-op. And here you can see the wrist is also loose. And here you can see the finger spasticity has reduced, but not significant as much as in the elbow, but you don't see a spring back sign. The pronator spasticity has been significantly reduced as we compare with the pre-op state. And on the opposite side, you can see there's no motor deficit following the contralateral C7. There's full wrist extension, finger extension, and elbow extension. And there was no significant sensory deficit in the area of the C7. There was some minimal sensory loss, but otherwise there was none.
Can he say his name? Huh?
No.
Can he say yes?
Muốn em mai nữa. Just that he finished the lunch.
Okay. Ask him what day is it today?
Ngày tháng này gì?
Okay, it's okay, it's okay.
Ở đây mà.
Can you count?
Yes.
count. 1, 2.
Món hộp vì mũi đo kìa.
This is his post-operative 1 month motor outcome. You can see that he's able to move the hand with less cognitive load, less effort because of the neurectomy. The neurectomy has reduced his spasticity. And note on his left upper limb, he has no motor deficit. He's able to use his hands for all the functions, showing that the contralateral C7 has got very little donor morbidity following the transfer. You can also note that he obviously hasn't got full function there. This is just a neurectomy and the transfer has been done. This is going to take the next 6 months to a year for it to the plasticity to occur centrally to improve the function in the right upper limb. But immediately you can see the cognitive load that's reduced.
It can be seen in this talk that the management strategies for spasticity in the upper limb and lower limb is evolving, and the role of neurectomy, highly selective neurectomy, and nerve transfers are improving, and there are more work that needs to be done. However, in the measurement of outcomes has been quite unsatisfactory with the current instrumentation that requires to have more fine instruments to measure the targeted interventions that have been done and not just a pure global outcomes. It's also important to understand the experiences of the patients as the cognitive load and spasticity affects function significantly. There requires to be more interaction in the multidisciplinary team involved in the care for post-stroke spasticity that requires counseling, education, and targeted research is needed for us to be able to gather evidence for the importance of surgery in post-stroke spasticity.